previous history of TBI, this definitely makes a big difference in patients who've had 4, 5, or more TBI history. That's going to potentially change what you're going to see in your exam. And when was the onset of visual symptoms? Are they improving, stable, or worsening? So that's also important. And are they working full-time or not? If not, how long have they been out of work? So work has so many implications. There may be financial strain and things like that you want to take into consideration. If they're working full-time, that may reduce how much time they have for doing the vision therapy. And have they made any adaptations or adjustments for their visual deficits? And that kind of tells you a little bit about the patient's personality. Are they someone who is going to do everything they can to try to make things work themselves, or are they someone who really wants you to provide all the information and all the guidance for their recovery? And lastly, have they completed vision rehab elsewhere? By what type of professional? What do they work on? So if you're seeing a patient that's, more chronic in nature, it would be good to know what they've done in the past, because that may guide where you would want to go with them. So sensory motor evaluation, we're just going to go over this really quickly. I really wanted to focus on the therapy, but I thought it would be important to know some key points that I feel like is important. So retinoscopy, and some of this may be things you already know, so I'll just go through it pretty quickly. Retinoscopy, latent hyperopia is quite common. So doing good retinoscopy, you may be able to find that prescription that would be really helpful for them. Horizontal and vertical phorias, so you can see where their eye posture is at distance and near. Horizontal vergence ranges at distance and near. Binocular instability is really common, so you will find that they may have restricted base-in and base-out ranges at distance and near. I always do vertical ranges with anybody with a hyperphoria or tropia, just because that can help guide us. Does this patient need the vertical? If they have really poor ranges, more likely. If they have really strong ranges, less likely. If they have suppression, because that will affect how well they respond to compensating prism and also guide them through therapy. Red lens near point of convergence, so you can see, are they using their accommodation to drive their convergence, or are they, so that will tell you if that's the case. And also accommodation testing for patients who are 40 years and younger. Fused cross-cil, NRA, PRA, and minus lens amplitude. And yoked prism walk to see spatially how are they able to orient themselves. So just a quick definition, neurovision rehabilitation is visual motor, sensory motor, and visual perceptual therapy to treat visual deficits arising from a central nervous system injury. Neurovision rehabilitation really includes all of these things that we talked about: therapeutic lenses and prisms, lens occlusions and tint, peripheral awareness, visual motor therapy, pursuing saccadic therapy, accommodation, vergence, multisensory integration, phototherapy, and reflex integration. So we're going to go over these in detail. I think sometimes it's helpful to categorize these visually symptomatic TBI patients. So I have just 5 categories that I've put there. So one is accommodative, ocular motor, photosensitivity, visual vestibular, and then multiple categories. The patients that I see that mainly have just the photosensitivity, their complaints are light sensitivity, difficulty working on the computer, difficulty watching TV, and difficulty with glare at night. Their sensory motor evaluation are often normal. This light sensitivity, these patients with a lot of light sensitivity, may be associated with headaches, pain behind the eyes, difficulty sustaining focus on computer screens or TV screens. And oftentimes you'll find the alpha omega pupil, where the pupil fails to constrict or fails to hold the constriction for 15 seconds. Then there are the patients whose main issues are accommodative. They're usually pre-presbyopes, and they really don't have any major vergence dysfunction. Their main complaints are blurry vision, difficulty focusing, difficulty transitioning from distance to near. You'll find pseudomyopia on your exam or significant change in refractive error. And it's also, these patients often have light sensitivity, and I wanted you to think about the sympathetic pathway. If that is, if they have an overriding sympathetic pathway, that's going to cause them to relax their accommodation and their pupils will stay dilated. The main patients who have ocular motor deficits, their main complaint will be closing one eye to see, double vision, difficulty looking at people when talking to them. And, very common is convergence insufficiency, exotropia, esotropia, fourth nerve palsy, and so on. The last category I call the visual vestibular. They tend to be the most symptomatic. They complain about vertigo, lightheadedness with positional movements, head turns, loss of balance, bothered by movement in their environment, difficulty in busy visual environments, and reduced peripheral vision, sensitivity to light. My examination findings in these patients will be nystagmus, vertical phorias, divergence insufficiency at distance, and convergence insufficiency at near.